All right. So talk to us about some contraindications, some scenarios where you see that, okay, yes, there's an active trigger point here, but because of the entire picture, this is not appropriate.
Yeah, so if somebody has maybe some psychosocial issues as far as emotional behavioral, they may not be a candidate for that. Are you screening them appropriately for that? Are they a catastrophizer, or are they histrionic, or are they borderline personality? Are we screening for those and making sure we are identifying these psychosocial variables that may not be a good fit for dry needling,
Mm-hmm.
right? Versus the person who we know is an adaptive coper. They're well adjusted. They have a good support system, and then we can make the decision and go ahead and needle them and have a good outcome. But you have to be able to predict what the response from the needle should be before you put the needle in a human being. Putting a needle in a human being, you should predict what the outcome should be, whether it's increased range of motion, decreased pain, increased muscle activation, increased function, whatever it is. You should be able to predict what that needle should be doing for that patient. And if you can't, then you shouldn't do it.
And that retest would be that validation that,
Whatever.
yes,
Yeah.
okay.
Yeah.
And if your prediction was not demonstrated on the retest, you move on.
Yeah. You move on, do something else.
Yeah.
Mobilization, manipulation, maybe some exercise, and understanding that, if I have somebody who has a peripheral sensitization, their ineffective nociceptors in the periphery are now active, and that I know they're not going to respond to exercise because they're going to be mechanosensitive. These patients are also thermosensitive. So I'm not going to put them with hot packs, or I'm not going to do a deep heat. I'm not going to recommend, a hot tub or a hot shower and stretching, because I know they're sensitized. And through temporal summation, that's going to be a negative effect for them. So I might use trigger point dry needling as a window in to reverse that peripheral sensitization and decrease the activation due to chemicals such as CGRP and substance P, nerve growth factor, all those neurokines that are out in the periphery activating the nociceptors. Or is it education on the patient why they're hurting, and that hurt doesn't equal harm, and that we need to engage the system. But we have to understand our pain sciences and what the role of pain sciences is in selecting manual therapy modalities, such as mobilization manipulation, dry needling, soft tissue, augmented soft tissue mobilization, tool assisted, whatever it is, knowing that we're matching that with the pain mechanisms the patient is presenting with.
A couple of quotes come to my mind as you're talking. I'm thinking about teaching a man to fish rather than feeding him a fish.
Yeah.
I'm thinking of one cannot permanently help another by doing for them what they could and should do themselves. Where does patient-generated movement and forces, and identifying what does this patient have and what can they bring to the table to get themselves out of this problem, where does that fall within the patient lying down and us delivering to them something where they just lie still and we are the delivery of the solution for them?
Yeah. So with me, the patient's always in control, right? So that's the biggest on anything that the patient that we're doing a skilled passive movement that is beyond the control of the patient. They always need to be mentally in control of what's happening to them. And that's the first
thing.
That
do you mean they concede that, yes, I'm allowing you, go ahead with this needle, right?
You need to stop, right?
Sure.
And that past it, right? It's just kind of like setting up for a manipulation. You set up for a manipulation. If it doesn't feel good to you as the clinician, you're not going to go ahead and manipulate it, right? You're going to reset it up, and it still may not feel good. So you have to have that intuitive sense. You may think you're going to start out dry needling, and all of a sudden it's like, yeah, this just doesn't seem like it's going to go. So there's manual techniques that are very effective for releasing trigger points that you don't have to use a needle for. We've lost the art of combination ultrasound and e-stim, right? I don't know if you learned combo ultrasound and e-stim.
Sure.
So the bottom line with that modality is I can cause a muscle contraction by going over the motor end plate. It's going to take me a little longer, but I'm going to do it through e-stim, and I can get some contract relax of the muscle fibers and get some release of the trigger point that way as well. That's a lost art. If you asked a graduate of a program in the last 5 years, could you do combo ultrasound e-stim? I'll guarantee you the answer is no. And what is that? Because we've thrown the baby out with the bathwater, right? And knowing more about pain sciences and the role of electrical stimulation in managing patients' pain, some things just need to come back, and we just need to use common sense regarding these modalities and why we're choosing it.
Sure. And I guess where I was going with that question to begin with, not to cut you off, but was not so much does the patient, are they mutual in this? Are we having some shared decision making here? But more of what can this patient do without me putting my hands on them or any instrument or any modality on them? What can they do right now and cause that difficulty and pain with raising the arm, and then some kind of patient generated movement guiding them, of course,
Yep.
but they perform it with hands off and with instruments off. And then, we retest and it's better. We know that that's healthy for a patient to have a
Sure.
locus of control.
Sure.
And does dry needling and other things, combination e-stim, ultrasound, do those things take away some of that locus of control?
I don't think so. If you're using, again, I'm going to come back to a sound clinical reasoning process. So, if somebody shows up to the clinic and I'm thinking they have peripheral sensitization, you keep moving that arm, they're going to hurt because they're sensitized. And the neurons are sensitive to mechanosensitivity is present. So I don't care how many repetitions you do. If it's peripheral sensitization, that activity is going to give them pain. And it may not be at that point in the clinic because of temporal summation and the C fiber stimulation. It could be a day later. It could be 2 days later, right? And understanding when a patient comes back and say, whatever you did the last time, it killed me. Oh, I missed it. I didn't even think of testing for peripheral sensitization. Right? So mechanosensitivity, thermal sensitivity, hyperalgesia. I need to look for those things, right? But if they don't have those things, then maybe unloading the arm by bending the elbow, right? Let's not have the person raise their arm with their elbow straight. Let's shorten the lever arm, and let's see what if we unload that tissue, can they get through the range of motion? Okay, that's better. Okay, what's the scapula doing as we get over 90 degrees? Is that scapula upwardly rotating? Okay, push on the scapula a little bit. Okay, is it moving? Oh, what does that do? Oh, that feels better. So are we doing all the mechanical things we know and do before we pick up the needle to put it in a patient? But I may also pick up the needle at that point and say, if I get this trigger point, I'll guarantee you this is going to be better.
Guaranteed.
And I've done that many times where you see the firing pattern's bad, go in there, needle the infraspinatus or the subscap or supraspinatus, and right immediately after, they're able to move through the range of motion. One and done, move on, start loading it, and start teaching them neuromuscular reeducation and some therapeutic exercise. So it's just the balance. And if you look at all the websites and the bashing and we are so immature sometimes. Right. And people want to tout the evidence. And if we have to tout the evidence in our profession, shut the lights off, close the doors, because there isn't enough evidence for anything we do. We have to be the consumers of the evidence and integrate that into a sound clinical reasoning process with our patient who is an N of 1.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.